So in Maastricht is a very small university. University not, but at least a very small hospital compared to all the hospitals.
You're gonna stop on Sorry.
Mr. Wise Guy. Anyways, you can imagine if you talk about research in Maastricht, it's probably not a metropolis in the whole world. But there is something here, at least in our anesthesiology department in the hospital, that say the people working there are proud of. And if you talk about pain research, it's also one of, let's say, the main centers in the world for this particular part. But it's something we will not discuss about. But since you are there to gain interest in things and so on, it's just good that you are aware of the stuff. Of course, every department probably has a certain focus, and the focus on pain in this university hospital is that there is a particular treatment available for chronic pain patients who do not respond well, or maybe not respond at all, to pharmacological medications, all kinds of painkillers. They're totally unresponsive, keep the same high pain scores as before, and then they say, okay, yeah, either you end up keeping the pain, or that's what they do. I mean, it's not unique in the world, but it's a big center for that here, Maastricht. And say, okay, we will test whether a patient is would be a suitable candidate for a more invasive procedure, and that would be for electrostimulation. So that's being done here. You probably also are aware maybe that the neurosurgery department also does electrostimulation in the hospital, like deep brain stimulation and stuff like that. It's a little bit different for the anesthesia. There, the chronic pain patient receives what we call spinal cord stimulator. So it's the same principle. You just have an electrode that instead of in the brain, you position on top of the spinal cord with the aim to close the gate. That these signals would somehow maybe reflect brushing of the skin or something like that. It would end up in the same kind of processes so that the gate would also be closed. That's what they call spinal cord stimulation. And spinal cord stimulation is there for a chronic pain patient, so usually it's a pain patient which has had that chronic pain for a long time, because spinal cord stimulation is something that is not started immediately, as it's so invasive. They will first start a whole arsenal of drugs available, and if everything is negative, then the patient may be considered for this kind of treatment. But the treatment is very expensive, something like 20,000 euros or 40,000 euros for one surgery. And that's because the implant itself, the electrode, that system is very expensive. It is made by Medtronic. Maybe you heard ever about Medtronic. So it's this company that makes these electrical devices for medical purposes. Actually, there's also one dependences here opposite side of the street. And of course they are, I mean, since they are one of the biggest companies for medical devices in the world, together with Boston Scientific, they of course still are looking for where to make more money. So they say, yeah, okay, it has been approved. I mean, it is clear that if you give patients with chronic pain, which is called a syndrome CRPS, complex regional pain syndrome, it's very frequently occurring, and if you give patients with CRPS, you give an electrostimulator on the spinal cord, that about 60 to 70% of patients you can get, it's not pain-free, but you can alleviate the pain to a level which is not clinically significant anymore, which means that it is bearable. And but it still means that there is 2/3 of patients which are also not responding to this more invasive therapy. And that's why there is a lot of research happening also here in the university sites, where we have the animal labs, that we are trying to appreciate in animal models why spinal cord stimulation in some cases would not work. Because if we find out that mechanism, we might, say, find a solution to it and get the other third of patients in the clinic also responding to this therapy. And of course, Medtronic sees a lot of dollar signs in their eyes because of that, and they support this research.
What kind of animals do you use?
Mice and rats, mostly, especially for this research, but it depends on the research question. We also work with pigs, but that's more anesthesia research, where you're interested.
Why? Pigs more of anesthesia?
Because pigs are very suitable to test oxygenation profiles, and so you can imagine if you want.
Comparable to you?
Yeah, also. But also suppose that you want to do blood measurements during a surgery, and you say, we want to measure the oxygenation of blood during a surgical intervention. If you would need to do that in rats, the rat doesn't have enough blood to let's say, get valid measures from. So then we need a bigger animal, and pig has been proven quite well suited for that. But it depends on the research. If you want to do eye research, a pig is also very suitable, because the eye of a pig is quite resembling a human eye. So it really depends on what you want to do, which animal you want to pick. So that is one side of the story, that is chronic pain and neuromodulation. So that is actually the main interest of the anesthesia center here. And when I came, it was all okay and I could participate in the research, but then I came a little bit older and they said, if you want, you can start your own thing. And then I started working on a different topic, which still needs to be seen whether or not Maastricht will be the best center to do this kind of research, that we will see. But that is on something that I will talk about today. That is not about chronic pain, but about chronification of pain. So having an acute pain patient, and perhaps that patient will develop chronic pain, or the acute pain will resolve and the pain will disappear. So the best way to study these kinds of pain chronifications is when you have a setting where I would say a patient gets perhaps the same stimulus, which is a surgery. It can be, I don't know, maybe breast surgery. It can be a mastectomy, where they remove the uterus, or a hernia repair, or something, just anything you can imagine, where supposedly the surgery is the same, but not every patient will develop chronic pain. So then you would say, okay, there it's interesting to compare the painful versus the non-painful and see what is responsible for chronic pain, so that we can come up with preventive measures. So I tried to symbolize that in this figure. So we have our patient here. It undergoes surgery, and the question is whether or not it will go to the left or to the right. And suppose that you want to know what decides to go right or left. You can say, okay, let's target that so that we are sure that it will go left. We just block the right road. But how to do that? How to get insights into these kind of things? Can you imagine something? You're a clinical doctor, you're having patients, you're undergoing surgeries, and you see some patients going that way and other patients going that way, but you don't know what the road is made of. How would you get clues about, let's say, the triggers to go that way or that way?
Compare them.
Yeah. How would you do comparisons?
What kind of surgical they had, and what kind of pain they acquire afterwards. So if you compare an amputation of an arm with someone of another arm, and then you can look at the procedure protocol and see, okay, what has been done, and you may find some differences why this one patient develops chronic pain and the other one not.
If I can ask you, just maybe several people will just give their gut feeling, because mostly it all starts with gut feelings. If you would say acute to chronic pain, what would you say, what probably could be predictive of pain chronification? What would you say, if you have that, probably you have more chance to get chronic pain? Just out of the blue, something that you would experience in life. Logically, I would expect, without a doubt, that would probably more chances of chronic pain.
Damage of neurons.
Okay, so you could get a nerve injury, possibly, because the hardware, let's say all these things that we looked at, all these pathways, if there is something diseased in there or damaged in there, probably that has structural and it's lasting somehow. It's not something that's easily repaired. So for sure, nerve injury could be a predictive factor.
Maybe age.
Age? Yeah, indeed. Age could be. What would you expect?
The younger you are, the mostly, let's say, the more capacity you have to repair
And how about the pain?
So I would guess then you wouldn't get chronic pain.
I would also, Intuitively, I would say the same, but actually, all people are usually protected from chronic pain after surgery. I'm talking really about surgery, not about diseases, but surgery. You often see this, and for me, that's also the counterintuitive. With age, it's a very good thing. What do you mean with that?
Some people have a low immune function, they will be more prone to be
Yeah.
So maybe then also gender, because they see that there is a difference in pain threshold.
There's more sense to everlasting discussion. I never saw real proof for that. I'm sure that in my relationship it is not. At least I'm complaining more. But indeed, age, gender, for sure. That's something. Let's say if you would expect these things, age, gender, nerve injury, maybe threshold stuff. How would you analyze that? Because you have patients which undergo surgery without chronic pain and others who do not.
So you group them both up. It's simple retrospective study.
Exactly.
Group both up. You have control. You have the cases. It's case control, and then you look at different things, and you have to look is it correlated with the other.
Exactly. You do correlation analyses. So correlation analyses are done a lot, and unfortunately, they're usually retrospective. So it means that we are now dealing with patients who had, I don't know, a thoracotomy, some kind of, I don't know, maybe heart surgery, and their thoracic space was opened for that, maybe some heart stent. We have patients now who have chronic pain after, and some do not. Looking back, and then you say, okay, what was their age at the time of surgery? What was their gender? And it's probably still the same, not necessarily true. So all kinds of things that you could correlate to pain. And then you will end up with predictive factors, and that's also what happens. And the question would be, I mean, here I talked about the same surgery. One patient developing chronic pain, another one does not. But the question would be, in how far is a surgical intervention identical? Probably not. I mean, you have different surgeons. Some surgeons are probably very precise in how they work, and others are the butcher type of surgeon. But it's really true. I mean, for me, when I started off like you, I also just have a biological background. I have biological background, but with just, I mean, that it's not at all, of course, let's say, based on real medical career, connection to medicine. But what helped me a lot is just watching surgeries. You know a surgical doctor, you make an appointment, and you visit a surgery. And you can see what a surgery actually is about. And it's really creepy sometimes. But that I can tell you, last week I was there. When you see that how they are, I mean, it's also necessary. There was, for example, a patient who received it already had an electrode implanted onto the cervical spinal cord. So it just means an electrode like this, under the bone, under the vertebra, on top of the dura. So it's not immediately in contact with the spinal cord, but it's on top. And the patient had diabetes, painful diabetic neuropathy. So because of the diabetes, there was some nerve damage that gives a neuropathic pain, and they get this implant, and then as long as it gives the electrical currents, the patient is helped normally. I mean, like I said, 2/3 of the patient, depending on the condition. Now, this lady received the electrodes 2 weeks before, and she actually showed a good pain relief during the two weeks of being stimulated, because it's like PCA, it's like patient controlled. And so she determines, she has like a little computer, and she on or off for the spinal cord stimulation, like a pacemaker, but this is really like patient choice to activate it. Now it's not needed, let's switch it on. Because of course, if you keep it on, battery needs to be replaced more often, so you can choose. And pain scores were really reduced to a level that they say, okay, this is enough to get a definite implant. And a definite implant means that the electrode remains, but it's now connected to a battery, and the battery needs to be implanted. So just under the skin, you get a little pocket. And I was looking at that, I never saw it before. And for me, you know, when you see old pictures in books, you think, oh, really look, implanted there, close up, and patient. But when you saw, I mean, I like to watch surgical programs on TV. I really find it interesting and not disgusting at all. But when I saw that, and then the reaction of the people, because this is an awake surgery, the patient is awake and she gets local anesthesia at the wound. But then, so they actually disconnect the connection with the stimulator. The lady is laying like this, for example. How do I lay it? Like that? and she has a cut here where the thing comes out. And they make another cut a little bit lower. Disconnect here. Then they need to make a connection between the two incisions. Because the connector is here, needs to connect to a battery, but the battery will be implanted on the lower side. But it means the battery is about this dimension, that there needs to be a pocket. Because it needs to fit in somewhere. I mean, there is not a natural cavity to put these kind of things. So that patient, and that, yeah. So it gets local anesthesia. Do you feel it? No, it's okay. So the guy starts. At a certain moment, so he goes with the fingers in, maybe 3 fingers like that. And that lady, oh, and you know, really, when you see that kind of movement under the skin of a person, and the person is well, I almost need to puke. No, but of course, I mean, she got local anesthetics, but you can imagine that it is also quite deep, and to get local anesthesia everywhere is impossible. So of course, I mean, you don't know that could probably also mean a bit of pain, I don't know, but when you see, that was not for me. But anyways, when you see these kind of things, I can give you another example. I watched a couple of surgeries, similar, the same. I mean, maybe the duration was a little bit longer with one compared to, but in general it's the same surgeon, also the same surgeon doing it. But I was but this is again gut feeling. If I would have to say, on which patient do I bet my money who will develop chronic pain? The lady, the first lady, and the guy after. And why? I'll give you an example. The lady comes into the room before the surgery. Totally stressed. The guy comes in. Yeah, surgeon, you never heard about the HEMA? Yeah, but the HEMA, you get these zippers. Just make a zipper. So when I need making jokes with the surgeon, I thought, ooh, that is a difference. And I'm sure, I mean, if you think about psychological factors like we discussed before, that if you talk about, so what I want to say is, if you look at a surgery, of course, during surgeries there is a lot of things which you could say, well, it will be so painful that perhaps it's such an impact on the system that the pain could persist. It's a surgical factor. But the rest, besides surgical factors, there are also probably patient-related factors. So for both kind of things, you could do correlation analysis. Yeah.
Is that a bit like if you think you're going to eat something and it tastes good, then it will taste good, and if you think something will... It's
amazing what your brain can do. I'm always amazed when I hear these things. I don't know this example. I should try it sometimes with the good food.
Oh, I'm not sure. It's just... common sense, my mother told me.
No, but here, it really is super important that you are making this remark and people start laughing. I'm telling you, the most things that I know are just simply because of experience in my life with my parents or my grandmother who told me something. I think, there is actually a reason much in it. It's not a coincidence. I just heard, it's connections that you make. It's not something that you learn being in this chair.
But is that the same, you mean, a patient comes in and is crying and thinks, oh, I'm going to have a surgery and it's going to be so painful?
I think yes. I give you one example. This is about a paper that I read not more than a year ago. And since 2006 I'm doing something with pain. And only now, so 5 years later, I read a paper that really amazed me. That was really just reading the paper. It was stated that in a study, I don't know how they got the ethical approval for that, but okay. And it was a decent, I think it was in the UK, I'm not sure about that. It was a decent hospital. And they had patients coming in for molar, molar molar removal of molars.
Wisdom tooth.
Yeah, something like that, yeah. And they said to the patient when came in, you will get an analgesic for it. Totally block the pain. And actually they give a fake drug to half the patient. That fake drug didn't do it. It was placebo. It was just saline. So that's what I mean. I don't know how they got the point, but here, there's only half of the patients received this. The patient said, pain. It's okay, it was okay. No big problem with the pain. So significant, low, yeah.
It was the same on Labyrinth. There's a program on Netherlands too.
Mm-hmm.
They done research to people doing the psychological effect of.
Yeah.
It was related to a natural body-made anesthetic, right?
Yeah, this is the same story, I think,
Yeah,
because it's
the
not so
same.
long ago. So half of the patients received the placebo, the other half of the patients were told exactly the same, getting back big analgesic and so on, but they received naloxone. You know what naloxone is? It blocks the opioid receptor. Let's say the endogenous morphine, let's say, blocks it. These patients did show a lot of pain. So it shows that if you expect to get pain reduction, your body starts producing all kinds of anti-pain substances. And that's why you actually do feel less pain. And that's something which is amazing to me, that the body, the mind actually makes pain or not. So that's also when you have a lady who comes into the surgery and she's crying. It's probably the opposite effect. It's probably she's releasing substances which actually evoke the pain. So I would also expect that, so let's say, fear and anxiety and stress, that they will actually be predictive factors. I saw this, and that was just, I also read about it, but when you see that, and I also, afterwards, I was sitting with a surgeon at dinner, and I said, so what is a more representative patient here? Do you usually see patients like the lady or like the guy? I said, I usually like the lady. And I thought, okay, that's probably a reason why we see a lot of chronic pain. I'm not saying that it's the factor that determines it, but probably puts a patient at risk. So you can do all kinds of correlation analyses. Usually we are studying it in a surgical setting because usually pain should be without pain before is being treated for something that ends up with chronic pain, of course, unintended. So if you look at a review, like meta-analysis, you see all these, let's say, retrospective studies being summed up, and you can see the percentages. So suppose you go to a clinic, any clinic in the world, I guess, maybe some clinics, but anyways, in general, so it's all good centers, and your hand needs to be amputated because I don't know what, or maybe the leg because you have diabetes, things dying, needs to be cut or whatever. You have 50% chance that you end up with chronic pain. 1 out of 2 patients. But there, I would say, yeah, okay, it's a limb amputation, it's quite severe, and you have chronic pain. For my logic, would say, yeah, probably would make sense. But when you look in inguinal hernia repair, Liesbreuk in Dutch, how many people have that? 1 out of 10 has a chronic pain. It's not a pain after surgery, it's a pain that persists for more than 6 months. That's not really normal, I would say. When I saw the numbers, I thought, oh my God. 1 out of 10 patients develops chronic pain. Cesarean section, also 1 out of 10. If you think that in America they are talking about making it standard procedure, because it's easier and you can just which when would you like to have the baby delivered that day? Okay, C-section. And then you say, okay, 1 out of 10 ladies, chronic pain. Maybe still doubt a little bit about doing that procedure like that. So I'm really saying that even with what is called minor surgery, you can end up with serious numbers of chronic pain.
How do you measure
Yeah. That is a very good question, of course. So it depends. Usually, let's say
That's what I actually do in hospitals. Don't they use like those smiley sheets and from a scale 1 to 10?
It's a pity. I don't know. I don't know whether I have it in this presentation.
No, you had it in the other one, and from 2.1.
Yeah. What they do is, it is the most standard pain test. That is actually spontaneous pain. So when you are sitting, are you in pain? That is what's asked by the doctor. It's like a question. Then he gives you a ruler, a line, which has 10 markings with equivalent distances. It says on a scale from 0 to 10, how much pain? 0 is no pain at all, and 10 is the most imaginable, and all the universe exists. And then you need to draw lines somewhere. And then they say, I mean, that's a rule in the clinic, that the doctors say, well, if it's above 4, it's clinically relevant pain in a sense that it needs to be clinically treated. But it's very subjective. But I personally, but again, a gut feeling that I have, it's totally not scientific, so don't use it in any argument, which is a scientific argument. But for me, there's nothing, I don't really believe in subjectivity of pain. If somebody puts a dash, suppose I give a pain stimulus, I give a heat stimulus of 43 degrees, and I say to you, how much pain do you have? And you say, VAS 3. Sorry, VAS is the visual analog score, that is that scale of 0 to 10. So on a VAS you say 3 out of 10, you. And then I do it. 7, it's horrible pain. And suppose that I say that, for me 7. I'm not convinced that, let's say that you are a tougher person than me. I'm not convinced. Although you would say, yeah, I'm a sissy and you're tougher. I'm a sissy. But for me, it could also theoretically mean that maybe my brain development has made a system where I have, let's say, a less extensive inhibitory signal from the brain compared to you. We get the same stimulus. Your stimulus, which is identical to mine, ends up in, let's say, an better inhibited system. For me, in a less inhibited system. So for me, of course, I put a 7, and you, of course, you put a 3. So for me, I also don't believe in craziness and stuff like that. There is a logical explanation found in the body for everything, I think. It's a very strong statement, I know, but it's my judgment. I also don't believe in weirdos, but that's another thing. So anyways, what I want to say here is that the VAS scale is the most frequently used test, but it is theoretically, that was how it's stated, a very subjective test.
When you have an amputation of the leg, some people can feel the pain in the leg. Yeah, is it also chronic pain or is it something?
Let's say it depends. It depends on that's referral. Yeah. It depends on how you would define the pain. If it's a spontaneous pain, or if it's a pain, for example, when you touch it, that it's more painful than touching the same area on the other side. Or you say, no, I'm having the amputated arm. Okay, that would be a phantom limb pain that you refer to. You refer to phantom limb pain. Okay, so that means this part is gone, and I say, oh my gosh, you have to spin your arms. Yeah, that can happen. And the reason is a little bit complicated. Actually, there's 2 mechanisms involved. One is that if you have, it's gone now here, but you remember the peripheral nerve fiber going towards the spinal cord. Normally, you have a generation potential only at the nerve ending in the skin. Normally, there is where you detect the stimulus, there is where you generate an action potential, and then the simple conduction to the spinal cord. So the generation of a signal starts only in the peripheral nerve ending. If you have a cut nerve, the situation changes. And it changes because if you think about what actually communicates the signal towards the spinal, it's all these ion channels which are in the membrane, voltage operated. They are produced in the cell body, which is in the dorsal ganglion. So all the time, continuously, you have production of DRG, and then by the microtubules, the vesicles, they're transported and deposited all over the membrane along the whole axon. Now you have a cut axon. You still have the transport of those vesicles with the ion channels. But now, I end up here. Well, there was a production enough to, let's say, decorate the axon entirely here. But where do they need to go? Yeah, let's deposit this end station. The train doesn't go any further. So you get a huge deposition of ion channels on this end. That means that the density of ion channels there becomes so big that you actually also get something like spontaneous electrical bursts. Simply because you have too many ion channels there. They're exciting each other in a way. You get a pathological condition there, which we call ectopic firing. Ectopic, because it's out of the normal place. Ectopic, extra topic, out of the normal place. It starts here, so you get a pain generation in this end. So you get, without any signal, you get, and then you say, oh, it hurts. Yeah, of course, because these fibers are active. They're not supposed to be, but they're active. And the fact that you think that this area, where it's totally not, is simply because if you get activity of fibers that were connected here, then you usually get cortical reorganization. So the parts that is, let's say, denervated, the neurons are not doing nothing anymore. They simply take over the parts from the ends here, which are doing the ectopic activity. So you feel all the time spontaneous pain from, let's say, this, while it's actually activity coming from here. So it's a complex between cortical reorganization and this spontaneous electrical activity. And that's also why in many of those cases they actually work with local anesthetics here. They put simply sodium channel blockers in here so that you get all the time an inhibition of that spontaneous discharge. But it's not, by the way, it's not only deposition of ion channels here, simply also the DRG where they actually are produced. They're also saying, they get also signal like, yeah, we are actually done there. We have so many, so they start also expressing a lot on the dorsal ganglion neuron. So 75% of this ectopic activity comes actually from the DRG itself. 25% only from the the ending, which is kind of, so yeah. This is chronic pain, which means clinically relevant pain at more than 6 months, and you see that these percentages are a little bit lower. But this is severe pain, so on the VAS scale would be above 5. Although it's a little bit weird that they came up with this, because usually people call severe pain above 7, but okay, in this paper they did above 5. And then here you can see, this is only in the US, how many surgeries are being done every year. Is it every year? No, that's not possible. Maybe every month. I don't know.
No,
Anyways, you can
one
imagine.
unit is 1,000 operations.
Okay. But anyways, you can imagine also on just logical base how many surgeries take place in the world, and if you think about these percentages, we are talking about a huge amount of people ending up with chronic pain. So there is a big clinical need to find preventive measures to make sure that we do not enter these large numbers. So for that we need to understand why chronic pain or why not. Because of course it is super interesting to know why patients develop chronic pain, but at least as interesting, why do some not develop chronic pain? Because there's probably something to find for protection. So if you look about, you can look at patient factors that are there before surgery, or you can talk about surgical factors after surgery. Of course, it would be super interesting to find things that you can already see before surgery. Because then you can say, that patient, that's probably going to develop chronic pain. That patient needs to get preventive measures. If it's only something that you say, if the surgery goes like that, then it's something probably you need to do during the surgery or after. So it depends how you can treat the patient. Anyways, if you talk about these association studies, here you see some, not all, but some of the predictive factors of chronic pain. If there is a nerve injury that we heard about before, if there is a nerve injury involved, big chance to develop chronic pain. But not necessary. It's not. It is only increasing the risk. The example is which surgical intervention always leads to a nerve injury. Irrespective, always. What do you think?
Amputation.
Amputation, obviously. I think there's nerves in here, so for sure there are dead. So amputation, but in amputation, 50% of patients developing chronic pain. So it's not enough to make chronic pain, otherwise we would have 100% there. If I tell you that in nearly every hernia repair there is nerve damage involved, only 10% of patients develops chronic pain. So it is a predictor in many studies, but it's not an all or nothing phenomenon. Then we have anxiety, psychosocial factors, genetics, it's all different factors. So you see patient related and you also see surgery related factors. This is something that was done here in the clinic before. So here they looked at, let's say, the minor surgeries. Yeah.
I don't know exactly what's psychosocial.
It's, for example, your social environment. Whether you have good family connections or a lot of friends or your social, yeah, more the environment. So social environment. So here they looked at patients who were undergoing daycare surgery, and they looked at what predictive factors they could find on the basis of correlation analyses. They saw age, like you said before, sex, so gender, I mean with sex. Pre-operative pain. Pre-operative pain, by the way, is also quite logical. I think the person already has pain coming into surgery, probably it will only get worse. I don't know. Then we come here, pain expectation. That's probably that lady who was crying because she was so scared of the surgery. Short-term fear, pain catastrophizing. That happens a lot, also with a patient. Probably was really going to happen some pain, but she was making far more out of it than probably needed. So it means a lot of psychological factors. So this predicts the intensity of post-operative pain, not chronic pain, because this is all only, this was a study where they looked 4 days after the surgical intervention. They said, which factors correlate with the amount of pain seen? It was these factors. Second study, same group. Again, day surgery. Again, 4 days after surgery. Again, age. Pre-operative pain again, pain expectation again, short-term fear. So again, the psychological factors and pre-operative pain, but that's kind of this. Then last year, again 1.5 years ago, we got this paper also from here. And here they looked at pain 6 and 12 months after surgery. So this is about chronic pain. So let's see whether we find the same factors. Not at all. The most important factor is acute post-operative pain. If you look at other studies throughout the world, you will see this as the most common factor. If directly after surgery you have a high level of pain, you're more prone to develop a chronic pain. The duration of the surgery and also the pre-operative physical condition. Whether you have a person who looks like that and only McDonald's and I don't know what, probably has more compared to an athlete or something. It's not, again, an all or nothing, but it gives higher risk. And this is particularly interesting, of course, because you can imagine that we are getting more and more the American style. I myself am also unfortunately sensitive to that. You have less time, you eat less on, say regular intervals. You also take the easy food because you don't have time to prepare something nice. So of course that also makes why, I don't know, weight problems or obesity even, or I don't know, all kinds of physical shapes get worse and worse, and probably also the chronification of pain will also get worse and worse in time. That's what I would call developed country diseases. Okay, so one of the most striking predictive factors is the severity of acute post-operative pain. Now, this is the reason why you will see in many parts of the world, in institutes, they say, well, if this is the case and we want to prevent a chronic pain, well, then we need to kill the acute pain as good as we can. And what do? They say, of course, put local blocks in there, which are blockers of sodium channels. We also inhibit inflammatory reactions. We inhibit, let's put morphine in there, tons of morphine. So they have all kinds of different therapeutic strategies to really reduce the pain as good as possible. And they call that multimodal analgesia. So let's say taking the pain away via multiple modes of action. Because what happens in the surgery, of course, you get a painful stimulus in the periphery. It's conducted to the spinal cord, and everything is sensitized all around that axis. Now, if you take a look at this scheme, this is a primary afferent coming from the periphery. This is a spinal neuron in the spinal dorsal horn, connecting somehow to a projection neuron, and that projects to the brain, and you get a pain stimulus. Of course, the synaptic communication here is essential because this is kind of the gate. Now, we can of course block the communication here, so we'll have less acute pain and also less chronification of pain. So how could we do that? Mention something. I mean, not the drug perhaps, but just, let's say, a mode of action. How could we prevent communication in the synapse? Yeah, indeed. So we could say, okay, we have receptors there. we will block the receptors. And that exists. You have ketamine, for example, that blocks NMDA receptors, so glutamate, the glutamate substances which bind to an NMDA receptor. We block NMDA receptors by ketamine. So ketamine is often used in these kind of approaches. What else would you do?
Prevent the vesicle from fusing with the
Yeah. How would you do that? So you prevent the release of neurotransmitters. Yeah, calcium channel blockers. Do you know about calcium channel blockers? Which ones there are?
Transient, long-lasting, and neuronal.
Let's say, suppose you could also consider, if, for example, take the example of a nerve injury, like the cut, and you have spontaneous discharges. What does it make you think about? Discharges, spontaneous discharges, not pain, just this pacemaker, yeah? Something else. The pacemaker is something that is induced. But really spontaneous discharges, say, do you know a condition where that is? There's spontaneous electrical discharge that you don't want. Epilepsy. So you will see a big overlap between epilepsy mechanisms and pain mechanisms, probably because we're talking about the same kind of phenomenon, different areas of the CNS or nervous system. So do you know what is used in epilepsy to block signals? Yeah, of course. You could say, okay, I will increase the potassium production and get more hyperpolarized states. But do you know what is mostly used as a drug, perhaps? Or let's say, which neurotransmitter would you like to apply that would have a good effect? GABA. So you just add inhibitory neurotransmitters, either benzodiazepines or GABA-erging drugs. So they came up with a drug they developed which would mimic GABA. They designed it very nicely. It looks kind of like GABA, the drug. And they said, great, because I have the same action. It also works. It reduces the pain. It works well in epilepsy. And the drug is called gabapentin or pregabalin. You know, GABA is in there, and that name somehow. You may know it in case that you have maybe somebody, you know, with chronic neuropathic pain or something, like Lyrica or the other drugs. You always have benchmarks, but the real drugs are pregabalin and gabapentin. What they actually found out is that it doesn't mimic GABA at all because it doesn't bind the GABA receptors. So it worked, but actually the drug didn't do what it was supposed to do. And what they found out, it blocks actually, that's why I mentioned in this context, it blocks the alpha-2 delta receptors, which are the calcium channels. So actually they bind the calcium channels, they block them. There is no neurotransmitter release, and by that actually they prevented the transmission. So it was a happy coincidence, because normally you could say, okay, the drug failed to do what it was supposed to do, but in this case it was no problem at all because it was also affected by a different mechanism. So that is often used, so you can block that. So you see that all these things, of course you can also use the local blocks, that you say, okay, besides the synaptic, I simply make sure that the signal doesn't arrive there, so I will block somewhere in between. I put local anesthetic, so sodium channel blockers on the nerve. For example, I don't know, with a patch, lidocaine patches. Lidocaine is a local anesthetic blocking sodium channels. Also what dentists use to anesthetize your mouth. So that is being done. But all these things actually act on neurons, neuronal communication. But you see that, of course, it's a neuronal synapse, but importantly, it's also the immune cells, which are outnumbering the neurons by far. So you have, I think, 10 times more immune cells or glial cells in the CNS compared to the neurons. And they're really closely connected. I mean, here in this picture not so much, but actually every astrocyte is like guarding the synapse. Now, if you consider that an astrocyte is really next to the synapse, and actually it can produce neurotransmitters. So an astrocyte can produce neurotransmitters. It also expresses neurotransmitter receptors. So what is actually the difference between an astrocyte and a neuron? Because a neuron is there to, I don't know, conduct a signal using neurotransmitters. receptors. The astrocyte also has that. So when people start understanding that actually astrocytes have the same kind of tools as neurons, they start understanding that there is not such a big difference between neurons and glia anymore, except that neurons project for long distances. But in general, an astrocyte can do almost the same tricks as a neuron can. It's even excitable. You will even see if there is a lot of neuronal activity that you can measure calcium waves in an astrocyte. So the astrocyte actually has signaling because the neurons are active. So all kind of calcium rises and decreases in the cell. So it's kind of communicating. It's also talking with the neuron. A different way, but it's talking. Now, that means that if you have an active communicator with a synapse, that probably that communication, if it would be increased in a pathological condition, would also make synaptic efficacy higher, which means also more pain. So let's see whether, in the multimodal approach, these immune cells would be interesting as therapeutic targets as well. Because if so, it means that we would also have to apply anti-inflammatory therapies and maybe also reduce pain. So is there indications for that? So we performed a study last year. Actually, we participated, was with a group in Brussels. And the question is, let's suppose that for whatever reason, you have a person that will develop a stronger inflammatory reaction to a certain stimulus compared to another person receiving the same stimulus. Well, would that perhaps lead to more intense pain? Because if this is the case, you can imagine, well, that means that somebody who is prone to develop a stronger inflammatory reaction, maybe because the person is obese and already has some kind of pro-inflammatory state, or I don't know what, that somehow because of that he will develop a stronger acute pain, and that predicts that it will end up in a chronic pain. So we have to treat that person specifically with anti-inflammatories to prevent as much as possible. So that would first need to be proven. So we went to an animal experiment because an animal model you can standardize very nicely. So what we used is a nerve injury, because after nerve injury we see strong pain in animals that we measure not with a VAS scale, but this is all induced pain, so we do not assess spontaneous pain in animals because it's very difficult for us to do. Although there's progress in the field, it's still not enough to say confidently that it's spontaneous pain. So we are applying a stimulus and we're looking at the reaction of the animal. So in order to make pain in the animal, we ligate partly for about half of the nerve, we are ligating it, and then tight constriction, so that all the axons in the nerve, which is the constricted part, they all die, like as if you would cut the nerve. And half of them remain intact, because of course we still need to have a signal production along the nerve, otherwise what are we going to measure? And then we apply a thermal stimulus to the paw. You can compare it with, we call that the electrical heating device, the cool. So this is, in this case, it's a laser. It gives a thermal stimulus. Tomorrow we will test your responses to this test.
Nice.
So you can either get really stressed about it, really anxious for the stimulus, or you go to the EMA. So the rat is usually habituated for something like 15 minutes, because otherwise it's exploring all the time, and then it's sitting still. And then we have the laser, which is just in the middle of the imaginary cross here. You cannot just see it completely still in the rat. So we just target that just exactly where we want to have it under the paw. We start the stimulus. Actually, I will show you first. So here we see the rat. And I'm positioning the stimulus, the heating. And you see a little purple light. That's a horrible quality movie. That's about the idea. So it's all the time now feeding that thermal stimulus. And the rat decides when it's enough. So after a while, it's enough. The thermal stimulus switches off immediately. And I can read on the indicator what was the latency, the time it took before withdrawal. And if you do this in a rat, and you say a normal rat will take 10 to 15 minutes before withdrawal. When you make a nerve injury, you see that if 100% of baseline, this is the 10 to 15 seconds, you see drops to about a quarter of the time. So after 3 to 4 seconds, there is already withdrawal now.
How do you say it was before the
What
not just bypassing?
Ah, yeah. Yeah, also a good remark. So what we, let's say, sometimes you have it that the rat maybe decides, oh now, I will move now. Go on. That you often see, or maybe it simply doesn't like it, or it's not painful, maybe it's like that. The only thing, because we have no idea, and that is applied to all the research almost in the world, because it's all of these like reflex behavior that we're assessing things. So the only thing that we're taking care of is that we say, well, we only score behaviors which are associated with aversive behavior. And aversive behavior is then, let's say, defined as behavior showing that he doesn't like it, as for example, licking. Probably if you don't like it, you don't start licking. It's probably something because your great grandmother that's cooler or something. That's our interpretation. You also tickling. Yeah, exactly. No, it's really fair remarks. But in research, it's the best we have. Let's say 2 years ago, or 3 years ago, the IASP meeting for the Neupsych as a neuropathic pain influence group was in Athens. There was a poster from a group in Denmark, which was looking at this kind of behaviors and comparing, let's say, the reflex kind of pain, whatever is our interpretation, with another test device. And that gave very striking results, although I would say that it was not a waterproof investigation, but what they did is, here they would say, okay, after nerve injury I have 25% reduction in the thresholds, which persists for, I don't know, maybe investigate for 4 weeks, but the full 4 weeks was decreased. And then said the same animals will now be placed in a chamber that consists actually of 2 chambers with a wall in between. And one chamber is very bright, another chamber is very dark. And a rat normally has a natural tendency to go to the dark. Because the dark is safe, because it's, of course, we have also rats, so if it's a bright light, they don't see a thing, they feel threatened as a prey animal. So they always go preferably to the dark area. So you see that in normal conditions, before any nerve damage, they spend, for example, 80% of the time in the dark. But now, the white area, after they got the pain, the white area is actually an area where they will receive a painkiller, so a drug that will reduce their pain, a well-known painkiller. So theoretically now they should spend far more time in the white. It's maybe a little bit more scary, but at least the pain is gone there. And this is a validated test for several pain models, but they show in many of the models like this one with the nerve injury, you see that there is no preference at all, or even they're spending more time still in the dark. So that would say, whatever reflex behavior is, that doesn't resemble pain, because otherwise they should have a preference now for the light chamber where they get painkillers. So you have a lot of discussion, but let me tell you also something that you know now because you're not yet in science, and just when you start. Many things in science are based on who goes first through a door, and the rest follows like sheep. It's always like that, and especially the person who goes through the door first, he's the pioneer of the field, with a lot of power and so on. And they will decide how the things go. And if somebody goes after them through the door, like a young person or something, who maybe like you, says, is that really true? Who are you to tell me that I'm wrong? You know, it's going like that. So everybody simply follows that line. And sometimes it's really good to have some fresh blood in there who goes against the mainstream. But it's not an easy road. So even though you are probably right in many of those aspects, the consensus still that people are using this, but I mean this discussion, what we're having now, it is already there since 5 to 10 years that are doubting about these tests, and still everybody uses these tests because they're so standardized in the field. Yeah. Companies who are really making painkillers, they're doing more and more these operant conditioning tests because they really want to make sure that they really find a drug that is effective. But in science, you do not see it develop so well. So here we again see immunohistochemical staining. Here we stained against the protein that is specific for microglia, and microglia are the CNS immune cells. We have half an hour still. IBA1 is the protein being stained here, so that only is the calcium binding that protein in microglia, so everything that is white here is a microglial cell. And this is how it looks normally. So you have nice round cells, nice cell bodies with long extensions. And you have very rich labs in the world, especially in Japan and China, and all these going stronger and stronger. These labs investing a lot of money in science, and they have brilliant computers, microscopes, and they do live imaging of cells also. And one of those meetings in Athens, there was one for Milan, they showed a video. I mean, it was really nothing, but when they showed it, and it's such a, let's say, state-of-the-art technology, everybody's like... So they showed something like this, but then showing the natural response of the cell. You saw a microglial cell, which started to see something that was not supposed to be there, I don't know, maybe some kind of pathogen, eating up that substance, and you could see that substance even within the cell and so on, so it was super great. Anyways, I mean, it's nothing else than what you read about phagocytosis. I know it's something that we know for many years, so just seeing it now in a live video is of course nothing special, but the technique looks nice, so that guy is famous. Anyways, if you would do live imaging, you would see that in a normal physiological condition, that cell looks like that. It has these processes are like tentacles, that you do all the time screening the environment, because that's what an immune cell does, immune surveillance, checking whether there is bad guys around. And if it sees something that is wrong, it will withdraw its tentacles, start undergoing hypertrophy, swelling up, and releasing all kinds of inhibitory cue factors to attract immune cells and start an inflammatory reaction. So that's what a microglial cell does. So this is in a normal rat, there is no pathological cue. If we now make a peripheral nerve injury somewhere in the peripheral nerve here, although the injury is super far away, because you can imagine that distance, we talk about nerves which are a couple of axons which are a couple of microns thick, so it's a super long distance. And still within the spinal cord we see something like this. Let's see whether the animation works. Yeah. So you see that the cells swell, they proliferate. So they are, I mean, this is an inflammatory reaction, nothing more, nothing less. You see a change in the morphology of the cells. These cells, we didn't stain for that, but these cells also start producing cytokines, these inflammatory cues, the molecules that attract other immune cells and so on. Now the question is, if you would have an animal, because back to the question, if you have animals, that was the original, which have a stronger inflammatory reaction compared to the same stimulus, would they also develop more pain? So that we tested, and we used a model which is very unconventional model, honestly. It's a transgenic rat model. There's not so many transgenic rats, but for this we have a transgenic rat. And this transgenic animal contains the human, let's say a mutated form of the human SOD gene. You know SOD? Antioxidant molecule. So it reduces the free radicals in your system. Now if you have an overexpression of a mutated human SOD, that means that the human SOD is not working very well. So you actually, let's say, you lack something in removing free radicals. So actually, when you get a pathological trigger that leads to free radical formation, you can handle the free radicals less well. And by that you probably get more immune reactions, inflammatory reactions, because you need to have more, let's say, soldiers in the immune army to fight the pathogen. So, how does it look normally? If you have a normal animal, wild type, so this is a normal rat, sham surgery, no surgery, no nerve injury. Microglial cells look like that, like you saw before. If you have a sham surgery, so a fake surgery and no nerve damage, in a human SOD1 rat, the same. Nothing special, kind of looks alike. If you now give a peripheral nerve injury to either a normal rat or a mutated rat, you see this. Now with a little bit of imagination, because this is of course only one tissue slide from one animal, so it's kind of representative. Just one example. But in general, I think you will agree that there is more white here compared to there. I mean, of course, compared to a normal situation, you have an inflammatory reaction, there's an increase in the white. You also see that the cells are swollen. But here, it looks like in the human SOD, one mutated rat, that the reaction is stronger. Looks like that, right? But you never know until you measure. So you need to say, yeah, it looks like that, but yeah, to my grandmother, it looks again different. So what is my opinion worth to my grandmother? It's nothing. So we need to measure. So how do we measure? Well, we simply put these sections. We put, for example, 10 sections per rat under a microscope. We delineate the dorsal horn, and then we say how wide is it? Put a number to it. And then we make an average per animal, and we have, for example, 5 to 6 animals in this group, 5 to 6 animals in this group, 5 to 6 animals in that group, and to that group, and then we compare the intensities that we find. Yeah, MSJ use. So, actually here we did not say how wide is it, but how much percentage of the area is wide and how much percentage of the area is wide. So the higher the percentage, the higher the area fraction that is wide, the higher the inflammatory reaction is. You see, wild types, if you make, in a normal rat, you make a peripheral nerve injury, you go from that white to that black. So this is the increase that you see from here till there. There's an increase in white, there's an inflammatory reaction. If you do the same in the human SOD, mutated animal, you see that the inflammatory reaction goes like that. So it's stronger indeed. This is of course far more important than what you see here. I think that this is nice to illustrate what you're looking at, what you're measuring. But of course, this really is evidence that this is really true, and not that you took out 2 extreme pictures to make your case. Because here all the animals are included. So this is really what is happening. So we have an animal model which develops after the same nerve injury. Develops a stronger inflammatory reaction. Yeah, I would say let's test now whether these animals also have more pain, because that was the initial question. This is about inflammatory mediators before. Interleukin-1 beta is one of the cytokines. You see that in the mutated animals, which have stronger inflammatory reactions, there is also an upregulation in this cytokine, and not in normal animals anymore. The reason why we selected this one is because interleukin-1 beta is one of the inflammatory mediators which is often linked to pain. And this is the results of the pain. In rats, you see the normal rats, which receive a nerve injury. And in green, you have these mutated rats receiving nerve injury. On the y-axis, you see the pore withdrawal latency, so how quick do they withdraw their response to thermal stimulus. So you see that although they both decrease over time because of the nerve injury over the first 3 weeks, that the drop, so the intensity of the pain is stronger for the green animals, which are the transgenic animals. So indeed, it shows that if you have animals which develop stronger inflammatory reactions to a nerve injury, they also develop more pain. Now, of course, you cannot simply say, okay, let's now go to the clinic, but at least it gives a clue that perhaps the degree of an inflammation after a surgery, or nerve injury, whatever, could somehow predict the intensity of acute pain after the surgery. And perhaps by that also give an explanation about why it would become chronic. Because that was the correlation, that an intense acute pain is more likely to develop into a chronic pain. So, nerve injury. Nerve injury leads almost instantly to electrical discharges, that ectopia that we discussed before, without reason spontaneous. A little bit later, a few days later, in the spinal cord, microglia will swell up, make an inflammatory reaction. A few days after that, you will see the same phenomenon in astrocytes. They also have a normal character, also swell up, also contribute to inflammation. So if you take this in mind, because this is something you can nicely do in an animal model. You make an injury and then you start looking at the process. You see, first we got the start of that ectopic activity. Then we get an inflammatory reaction of microglia and that astrocyte. But yeah, how to do that in a patient? The patient comes in, got all kinds of drugs, didn't help at all. Yeah, what to do now? Where are we? Because then we can also see which process is maybe the most prominent at that time. We have no clue. So to simply say we are putting all this information to clinical trials, but we're not. In a post-surgical setting, it's a little bit different. That's also why I have a little bit hope that this will actually bring something. Because you know exactly when a surgery is planned. You could say if inflammatory reactions matter, you start it immediately. Where it's so somehow, if you have a whole chain of processes, at some point you need to break it. Well, I think the first thing that if you talk about nerve injuries, because like the person here in front said, nerve injury is a very important factor for the development of chronic pain. So we are usually focusing on nerve injury. And I think if you start somewhere, let's suppose we come in here in the morning, there is somebody dead on the floor, and there is some blood, a pool of blood next to it, there is a knife, and there is